My name's Peter Mallet. I'm a paediatric consultant at Children's Hospital. I'm joined with Dr. Shauna Malloy, who's a paediatric intensivist here in Children's Hospital. And we are going to talk to you about acute asthma for the next 20 minutes. The reason why we were doing that is because asthma is a very common condition and it's encountered globally. We know that its estimated prevalence is around 1 in 10 children and young people are affected with this reactive airways disease. We also know that in some cases it can be under-recognized. It's sometimes difficult to ascertain the true clinical extent, and we know that in many cases management can be optimized. Ultimately, the reason why it exists and is continually discussed on these pediatric emergency conferences, a topical and important condition in any critical care conference or meeting, asthma can kill. Before we talk about this, we wanted to frame it around a hypothetical case to discuss and tease out some learning points that might be useful for you as a healthcare professional in the setting that you work, whether that is primary, secondary, tertiary, or in urban or rural healthcare setting. So this is a 14-year-old boy who was previously well. His only relevant past medical history is that he had very mild reactive airway diseases managed with minimal dose inhaled corticosteroids and by his primary care physician, and no previous hospital admissions. However, he presented to the emergency department unwell for 1 week. Further history showed that really he had a productive cough for about a day and had described some central chest pain, which was unusual for him. He was noted to have quite significant increased work of breathing and was hypoxic on initial triage, with his saturations around 85–86%. First question, hopefully we try to engage you, is if you were seeing this patient in your healthcare setting, what would be on your differential diagnosis of what's going on at the moment? Include after reviewing the patient, taking a history, examining, and getting a baseline chest X-ray given the presentation. And we'll allow you, hopefully you'll be able to see that and engage, and we'll give you 15 or 20 seconds. Again, not to be blinded by the topic in terms of our discussion, but if this was objectively what you would met, exactly that, what would you consider amongst your differentials and your most likely diagnosis? Because all of those are relevant differentials. What would you say is your presumptive diagnosis at this stage? So we have about 40 people registering their vote, and we can see there's generally a 50-50 split for people thinking community-acquired pneumonia. Some are suggesting an acute exacerbation of asthma, some saying a viral LRTI, and often many of you will be saying, well, possibly both, maybe an infective exacerbation or co-pathology. Moving on into this case, the young person was assessed and venous access was established, and a baseline venous gas was performed with the results shown as there. And the most notable abnormalities was that was a significant acidosis, elevated PCO2, and elevated deranged base excess and bicarb. So the initial management included 100% oxygen or 15-liter oxygen via a non-rebreather mask and back-to-back immediate continuous bronchodilator nebulizers, administration of oral steroids, and broad-spectrum antimicrobials to cover the possibility of infection. However, the child was noted to, again, be persistently or worseningly tachycardic, remained to have a significant amount of respiratory distress, and was significantly hypoxic despite 15 litres. Most concerning for the clinicians involved in this patient's care is that there had been a clinical deterioration with regards to their GCS, and it felt that clinically they were becoming more tired. What would you do at this stage if you were the responsible clinician in your healthcare setting? The options are included there. Thanks for engaging with us, and we'll give you about 10 or 15 seconds to see. Again, many of you will be thinking, maybe I would do all of these, and that's entirely reasonable. But if you were trying to pick one first action you would do, you give some IV Mag-Sulf, would you start other IV bronchodilator therapy, give intravenous steroids, immediately prepare for intubation, or commence some non-invasive ventilation? The vast majority of you are saying that IV magnesium sulfate you feel would be most appropriate in this setting, although there are some contributions for other options as well. In this case, given the degree of significant respiratory distress and clinical deterioration, the emergency team contacted the pediatric intensive care team, and an immediate consult was facilitated.
So, deemed sick enough with the hypoxia essentially to be transferred to PICU for further management, and was transferred to PICU with PEEP by the Mapleson circuit. Child was compliant with this. Stats were 70 to 85 on 100% oxygen, so we're still struggling in terms of hypoxia. And in terms of overarching clinical condition, both the completing sentences was not talking comfortably. So was taken to PICU. Intubation was prepared for, and this is just a signpost to our pre-intubation checklist, which can be found on Paediatric Emergencies, and you probably have your own in each of your own institutions. Just outline your prep prior to intubation. Child was intubated. Was all fairly straightforward. The view was a grade 1 view. Did run into some difficulties initially in terms of the initial inspiratory pressure was very high when placed on the ventilator and needed quite significant pressure when initial bagging to inflate the chest. It's very, very tight to bag as we talked about, and whenever they listened to the chest, there was a mild audible wheeze. This is just a picture of an example of what was represented on the ventilator. So we're just going to ask you now, just in terms of that, just to freehand, just say what you see for your.
You're able to contribute if you are in a district general setting or your waiting retrieval team. Think if you were to see this on your ventilator, how would your team react to this? Describe what you see. Yeah, and this is free text contribution, so we'll give you 20 or 30 seconds to contribute. Suggestion of high pressures, prolonged expiratory phase, not fully expiring. Some useful contributions here. A few suggestions for gas trapping and high risk of pneumothorax, incompleted expiration phase. Wiggly lines is what I would see as a pediatrician. I would be needing help from my intensivist or anaesthetist, but this is a useful learning for all of us. Excellent. Excellent. Good contributions there. So moving on.
So essentially, gained some stability on the ventilator, and we got a post-intubation chest X-ray, which showed this. So just in keeping with, and think about your initial X-ray, and this is the repeated X-ray, what would your likely diagnosis be now?
This is, again, just to reframe it now that the clinical story has evolved.
So still an overarching percentage of people would go for a community-acquired pneumonia with an acute exacerbation of asthma and fairly low down there in viral LRTI. Great. So continued management with the mild wheeze, the clinician decided to give continuous nebs then via the ventilator, back-to-back salbutamol and ipratropium, 3 sets back-to-back. Initiated IV aminophylline, so initially gave a bolus followed by an infusion, and gave repeated boluses of IV mag sulf, which is a potent bronchodilator, and added in intravenous steroid, now hydrocortisone. This was then the post-intubation gap once the child was intubated. So again, we're seeing acidosis here, mainly respiratory acidosis with a PCO2 of 9.5. Lactate's okay. Your venous saturations are good at 74%, saying, and this was from a central line. So how would you ventilate this patient with what was going on? You've got a tight chest, you've got high inspiratory pressures, you're finding it difficult to actually get them onto the vent. What would your strategy be?
So remember, we're framing this for your expert consultation or advice, and you're met with this patient. For example, in a district general setting, awaiting anesthetic, or you've got anesthetic assistant, but awaiting pediatric intensivist advice. So some people are suggesting long expiratory time, low respiratory rate. Someone suggested with fear and trepidation, which is absolutely understandable. A prolonged expiratory phase until accept a degree of hypercapnia. Very good.
So we took some of those suggestions on board and we'll talk through the actual or the what we would do in real life in the discussion afterwards. But we ran then further in this case, there was a few further difficulties in terms of a labile blood pressure. With this age of a child, we were aiming or aim for was for a MAP of greater than 60. But currently and intermittently, the blood pressure would drift down to less than 40, and what your working diagnosis would be. What would you think the most likely cause of this hypotension, this intermittent hypotension, I should say, would be? The majority there of people saying gas trapping.
So really moving on from this, we wanted to spend the time to discuss some intricacies around acute severe asthma recognition and the management. As we've alluded to already in our discussion, this is an extremely common condition and a potentially very severe condition. Some of these are the clinical features associated with an acute severe or life-threatening exacerbation of asthma. Many of you will be aware of your own local guidelines or national guidelines that recommend and recommendations suggesting these. But really, some of the key pertinent features that we need to consider very seriously are if children or young people are unable to talk or feed, if they are breathless, if they have significant hypoxia, or if they, as we've discussed before, have a disproportionate or very excessive tachycardia or tachypnea. The overarching principles of managing an acute exacerbation of asthma is for the basics to be done well and effectively. So if possible, to position the child in an upright position with high flow oxygen and immediately administer some bronchodilator therapy in the form of nebulized medication with suggestions as below. Moving on to steroid management, there are several different options between oral and IV. We're aware that in lots of centres and globally, some centres will prefer oral prednisolone, some centres will prefer oral dexamethasone, and there has been significant studies and research investigating this. The overarching take home would be really, it is where what you are familiar with, what you are comfortable with, and what your centre promotes on an evidence-based basis. Equally, if children or young people are too unwell or unable to tolerate the oral route, there are IV equivalents in the form of hydrocortisone. And following this, moving on to IV bronchodilator therapies and other agents. Again, centres will vary around the world in terms of what you prefer, but it's well established within our centre and other centres nearby that the first line management would be dose of IV magnesium sulfate, which has been proven and shown to be extremely efficacious in the management of acute wheeze. Thereafter, depending on clinical response, subsequent treatment depends really again on centres and clinician preference, bearing in mind the evidence base and whether the patients can tolerate this. IV salbutamol in the form of a bolus or infusion, or IV aminophylline. Again, we can discuss with our panel in due course what preferences are. It would be useful for you from this to go back and talk to your colleagues in terms of what your policies and guidelines are and where you currently sit in terms of your preferences.
I think it's important to add in this also that, from a DGH level, sometimes people can be quite cautious with mag sulfate. It's brilliant bronchodilator. We would, Peter, you were saying that sometimes there's use it 12 hourly.
Yeah.
But we would advocate for, keeping levels above 1.2. We're not really reaching toxic levels until, above 2, 3. So it's really good.
10 minutes, guys. That's okay.
From an IV salbutamol point of view, like the thing we can just stress is that, ECG, IV salbutamol and aminophylline should be ECG monitored. And when you're using your salbutamol, there's evidence for a bolus, and your max is kind of around.
Guys, your volume keeps on disappearing.
From an intravenous point of view, 20 mics per minute. F is 1 to 5 mics per kilo per minute. But 20 mics per minute would be your max. It's of around 20 kilos. After that, you're going to run in terms of, hyperkalemia, arrhythmia, tachycardia, and lactic acidosis. So those are just things just to keep in your mind whenever you're prescribing these. In terms of what you use, I suppose, again, depending on your actual institution, but I think the main aim in asthmatic is not to have to put in a tube down. So, if you have the means of throwing everything at a child in order to avoid intubation and difficult ventilation, I think that's what you should do. The also thing to consider here is a differential diagnosis, which is what we were kind of trying to stress in our case, where, it could look like a lower respiratory tract infection, or it could be an infective exacerbation of asthma, and it could be any of the actual differential diagnoses mentioned in this table. So would you intubate at this stage? So at this stage for an asthmatic, I think you should be very afraid of intubation in an asthmatic, not the actual intubation process, but how you're going to ventilate them afterwards, because they're notoriously difficult to ventilate. And that's all through the scales. So we want to just think about here, how we optimize their medical knowledge. The intubation will be straightforward, but the actual decision to intubate shouldn't be taken lightly. And that's where non-invasive ventilation comes into play. We have the means now in Northern Ireland to actually transfer on non-invasive ventilation. And I suppose the one most commonly used in a district general hospital would be high flow nasal cannulation ventilation. And I do not, does not meet any criteria for intubation, as in has lost, is very drowsy, GCS is dropping, and we'll talk through the indications. I think high flow prior to intubation, or thinking about intubation, is a completely reasonable resource. Non-invasive in terms of bypass, there is more evidence for, and that it will not fail, but I don't think probably that would be a reasonable initial. That would probably be something that would be employed once you get to a HDU or an intensive care situation. So before any intubation, I definitely think you should be discussing, if you're thinking along the realms of an asthmatic, you should definitely be discussing with a PICU consultant or indications for intubation in terms of asthma would be working on hypoxia, which I've had, and SATs less than 92% on 100% increasing PaCO2 and the worsening clinical contents in terms of per gas exchange. As we talked about, altered consciousness or progressive agitation and non-compliance with what you're trying to do, and obviously in a cardiorespiratory arrest, which can well happen in these kids because they are so fragile. And before intubation, you really need to consider all your all your life-saving medications, because this child has a massive potential for an arrest during the actual intubation process. So intubation, as we said, is always a very, very high-risk procedure. It should be the most experienced clinician. This is not one for, first-time intubation trainee. Pre-oxygenating 100%, oxygen for 3 minutes. I would consider some pre-intubation nebulized salbutamol, post-intubation bronchospasm. You have a fluid bolus ready, 10 to 20 mL. Resus meds, including your push dose. Adrenaline. Always use a cuff tube. You don't want to mess about. You're going to need high airway pressure. You don't want to be losing pressure. Don't change from an oral to nasal. You've got to be sure that there's no need. It's a fragile case. Consider a modified induction. And in terms of your actual induction medications, ketamine is very useful as we talked about. I think Ben mentioned about it. Use 1 to 2 milligrams per kilo. It's got good bronchodilator qualities as well. I would avoid morphine and atropine if they're high histamine release. Fentanyl doesn't have as high, but there is some histamine release from cause and effect from that. So I would use ketamine. Is there an issue with my volume?
Yeah, every now and then it's just becoming very muffled. So I don't know if one of you've got your hand on the mic or something like that, but it becomes very muffled and hard to hear.
Sorry, is that better?
Yeah.
So talking about post-intubation management and complications, as I said, be afraid of ventilating an asthmatic. It's really hard from experience. Any intensivist will tell you that they're not the easiest to manage. You'll be prepared to be up all night. Immediately, you're going to slowly bag from access for expiration and expect per chest rise and the sats to drop, and you're going to need high pressures initially. Use your end tidal, use a chest your chest x-ray to confirm your tube. Expect an element of bronchospasm, and that's why you might think about using pre-intubation salbutamol to post-intubation bronchospasm. Air trapping, gas trapping that we talked about and you saw on the ventilator side. You have a big expanded chest. You want to allow time for expiration to avoid this. So, start with a normal ventilation rate, but you may have to reduce your ventilation rate. If you do have gas trapping, which you will see that your expiratory rate does not go back to your expiratory flow does not go back to the baseline. Disconnect the patient, listen for a hiss, and manually decompress. This will also, that's the reason why you have hypotension in terms of gas trapping. You've got this high intrathoracic pressure causing dynamic hyperinflation. So just by manually decompressing, your venous return is not impaired any further, and your blood pressure is restored, and that's why it's an intermittent hypotension. You also have issues where you may have high insensible losses. They've been sick for a while. You've had reduced oral intake. All those reasons is why you may need some further fluid. And hypoxia, obviously, you're dealing with reactive airways. You've just intubated a child. You should always think about your dopes. These kids are not any different to any other kids. You may have displaced the tube, maybe not in the right place, maybe obstruction from secretions, a pneumo, equipment issue, and again, the gas trapping, which we talked about. So, how you want to ventilate this child is reduce your respiratory rate, start with physiological respiratory rate, and then reduce that. Reduce your tidal volume, and by increase your inspiratory time. So, use the pressure regulated volume for tidal volumes around 46 mils per kilo. Rate is normal, as we talked about. Start with an average times 1 to 2, but mainly to increase up to 1 to 5. Use the normal PEEP around 4 to 7, around 5, 6 probably, and aim for may need to go higher in the initial stages. Some initial therapies, which you probably would not be using in your DGH, but that we will employ here. To more laminar flow and lower your airway resistance. We don't have that in our institution, but it's something that you can think about back in mind if you have it in your setting. Ketamine, as we talked about, has great bronchodilator effects, and you may consider that as part of your sedation regime. Placebo, which with the anaesthetists among the audiences, you may use that to gas the child down initially. and it's a good bronchodilator, but also and causes smooth muscle relaxation. But also you have your added side effects of lowers your blood pressure, so you have to be quite observant of that. Adrenaline also, there's some overlap with anaphylaxis. Low doses of adrenaline would stimulate the beta adenine receptors and it bronchodilator. No real evidence for meds adrenaline, but we would probably back end of an exclusion. Yes, for the DNA, again, leads to, exacerbate the problem, and should be probably done with concept of this is getting clearance, so it's something that you can think about. And obviously, if you're really Peter in Glasgow and talked about asthma with utilized all these additional
Really, this was a brief overview of a common condition with potentially devastating effects. So some of the learning points that we'd like you to take home from today is in any clinical encounter, obviously think before you leap with regards to diagnosis and initial management and the possibility or probability of co or multiple pathologies. Really to reaffirm the issue around labile blood pressures and to think in the clinical setting that hypotension obviously isn't always sepsis, as we've discussed here, and really to never underestimate asthma, which I know that many clinicians do not do. For your benefit in terms of additional reading and further learning, we have Science posted some resources for you. Chris and the Paediatric Emergency team's excellent piece and podcast. There's a good asthma module on Don't Forget the Bubbles, and this is a signpost for the Global Initiative for Asthma as well. So thanks a lot for your attention, and we're happy to discuss with the panel.
Thanks very much, Shauna and Peter. We're about 5 minutes over time. Might be worth it if there's one or two questions, taking those quickly before we move on. So I see in the chat there's a bit of discussion around IV use of magnesium sulfate versus IV, or nebulized magnesium sulfate versus IV, and also IV bronchodilators. I mean, that's an ongoing sort of discussion.
It shouldn't be. Nebulized magnesium doesn't work.
Yeah, and I think that the reason it keeps coming up now as a discussion point, I think, is the BTS guidance does say consider, it's great, the evidence, but that was published in the basis of the magnetic trial, which was 2014, which showed some potential benefit, but there's a really large trial across multi-center trial across a number of centers in Canada, published in JAMA in 2020, which really didn't show any significant difference whether you got magnesium sulfate nebulized or not. So I think IV magnesium sulfate, there is evidence for it. Nebulized probably doesn't do any harm, but there's not a lot of evidence to say it makes any difference.
It is in the new APLS algorithm booklet. It says consider magnesium nebulized, which I've never seen it before, which is strange.
Yeah, and the BTS guidance says consider it, but it's just the evidence for it is poor, but there is evidence for IV magnesium sulfate. Peter's got his hand up.
Yeah, I'm driving, so I don't know if you can hear me. Can you?
Yes. Yeah, I still hear you.
I mean, this is a topic that I could talk about for hours. Okay, so this is not something that will be covered in a half-hour talk. It's a whole day in itself, and the pitfalls are many and they are mighty. But to be clear, a child arriving in ICU, unless they've got fixed dilated pupils with asthma, their mortality rate should be pretty low. And I mean like less than 1%, 0.3, something like that. So, asthma needs to be managed well when it gets to the ICU. And there are certain things that there is evidence for, and there's certain things that there are not. And some of the evidence dates as far back as the 1800s. It's not even recent evidence because it doesn't need to be. And we don't need to reinvent the wheel. So, when we talk about these patients who are hemodynamically unstable because they're gas trapped and there's no blood, getting in terms of venous return, the minute you decide to apply pressure on their chest and totally occlude their IVC, you might just cause a cardiac arrest in your attempt to help. So I would be very clear that I do not ever support manual decompression. However, the caveat, if you want to sell it to me, asthma is very clear in terms of the triad of pathophysiology, and not one person is really often talking about the mucus plugs that form. And I've already talked in my talk about the role of DNAs. These patients should get aggressive physio. So aggressive physio will cause the same physiological response as a manual decompression, but you're doing it for the correct reasons to address the pathophysiology. So be cautious in following guidelines without thinking about the implications physiologically on your patients. And do not forget mucus plugs. Now, magnesium has got mucolytic properties, so I can support it, but don't forget about the other things that go alongside it. And if you poison patients with IV salbutamol, be careful. But I could talk about this for hours.
Thanks, Peter.
Yeah, to piggyback to what Pete said, there's absolutely no need to give IV salbutamol when you already saturated every single beta receptor, which are finite, and this is again evidence-based, with nebulized salbutamol. You're just giving the same drug twice, doesn't make any difference. So in terms of pharmacological benefit, for me, aminophylline makes a lot more sense. We have better ways in monitoring aminophylline levels now than when we used to see aminophylline toxicity 15, 20 years ago with seizures and all sorts of stuff. So old school pediatricians hate the stuff because it used to cause seizures and lots of side effects and cardiotoxicity. Not anymore, because we're much more hot, not just in tertiary places, but DGHs in checking for aminophylline levels. So pharmacologically it makes a lot more sense. And the forgotten bronchodilator is obviously adrenaline, which they rely on a lot more on mainland Europe than in the UK and Australasia, but it can really work wonders when you're stuck on a downward spiral. So a croup dose of adrenaline is well worth trying if you're not winning.
Yeah, I would have to say I agree with certainly some of what's been said about IV salbutamol. To me, it does make sense to start with magnesium and aminophylline because you've already got salbutamol in the system and you're going with a different drug. But I think we've all seen patients turn round and avoid intubation by starting IV salbutamol. So it definitely does have a place. It's in all the algorithms. But for me, I agree with what the guys are saying. It would be the third choice, and just be careful with the dose. You're not going with big doses. And I generally then would stop the inhaled treatment and run the IV stuff. Manual decompression, what Peter said, there's no evidence for it because no one's ever going to run a randomized control trial over disconnection and leaving the patient versus manually decompressing the chest. I've done it lots of times, and you get an instant result, and no one's ever arrested during it. But it is a theoretical risk, and there's no evidence one way or the other whether it's the right or wrong thing to do. But whatever you must do, if you've got a crying asthmatic who's on a ventilator, the first thing you do is disconnect them from the ventilator, plus or minus manual decompression of the chest.
And I would say in a DGH, yes, your chest physio and your DNAs, if you're in an ICU situation, but in a DGH, you'd be quite cavalier to start, as opposed to a manual decompression, to start DNAs and chest physio while you're prepared to transfer the patient. So
yeah, I agree, Shauna. I would not support DNAs and stuff. DNAs in a district general. Absolutely agree. I'm very specifically talking about ICU management in terms of we should have a low mortality. And I try my best not to talk about DGH management because they should follow the guidelines that are out there, rather than an ICU way of addressing asthma. The point is more to think about all points of the pathophysiology, but I totally agree with you. I have never advised somebody to use DNAs in a district general, only ever direct installation via bronchoscopy actually in an ICU. Yeah, so I agree.
I think the caution with physio is that while you're doing it, I've seen patients nearly arrest from air trapping during it. So if the physios are coming to treat a patient in the ICU, I'm standing at the bed, and in fact, I'm doing the bagging for them while they're doing the treatment. But it's absolutely massive what Peter says about going after the mucus production and the plugging, because everything that we do in asthma, we get distracted with a bronchospasm, and that might not be the whole cause. So you have to go after everything in these sick patients.
Yeah, and just bearing
Thanks.
in mind that, you know, the autopsy studies from the 1800s show that these people that die of asthma, their airways are just absolutely full of plugs. So, you know, it's I don't know why it's the forgotten part of a triad of pathophysiology, but for some reason it is.